we're going to be looking at this case over here. So while it just loads up, I am going to just download that one and make this full screen. We have got another abdo-pelvis, youngish patient. Feel free to throw in what you think could be going on. So with this one, we've got a young patient. Don't get put off by what these things are. They're probably just artifact from this patient. Yeah, exactly, two-ring artifacts. It could be a belt. And I actually do remember when I was a young gun back in the day, there was someone with abdominal pain and we did the x-ray and I got really stressed out because it looked like they swallowed lots of metallic artifact, and I ran in to quickly examine them and it turned out it was just the belt. So there you go. So this could be just something artifact from it could be just artifact from some of the patients wearing. But when we go back to sort of basics of x-rays, we're looking at the bowel pattern in particular. So within the central abdomen, you're going to get a whole lot of small bowel. Along the outside of the abdomen, you're going to have the large bowel. And this large bowel doesn't look quite right. Exactly. So well done. A few people have thrown in their answers. Well done. So what you can see is that this looks like the transverse colon, but you don't have that sort of normal kind of cloudy appearance. You don't have what is known as haustral, these lines that go incompletely across anywhere. This looks almost like a cucumber or like a tube, doesn't it? Like a lead pipe, someone might say. It just looks very, very featureless. You see, I'm throwing all these lines that are kind of, these are the lines that people want to hear when you're doing the radiology exams or when you're doing your exams or even your report. As soon as you say certain phrases, it means certain things. And in this particular situation, when you say featureless, lead pipe appearance to the large bowel, you're kind of only really saying one thing. You think about inflammatory bowel disease. So this patient's come in with abdominal pain and we've done the CT scan. So why would someone with abdominal pain, and let's say they've had that x-ray, and they've always looked like that. So if they've always had this problem, why on earth we're doing a CT scan? It's because when someone has got inflammatory bowel disease, they're going to be predisposed to certain things. And one of the things that they can have is something called toxic megacolon, which is something that kind of acts like a bit of an obstruction. You could also, exactly, well done. So they're going to have Crohn's, but I'm saying that if someone's got Crohn's, why would you do a CT scan? And the reason is that they're also predisposed to perforations, so they could get perforations. The inflammation can result in fistula, so connection between bowel. So that can, and you can get fistula between the bowel and the skin, between bowel and the uterus. You can just get connections between places as a result of the multiple inflammations that can happen, which CT is very good at looking for. And and then obviously someone who's got Crohn's disease, ulcerative colitis, they're going to have a larger proportion of those kind of patients are going to have the possibility of having a malignancy. So when you get patients who've got known Crohn's disease or any sort of inflammatory bowel disease, I tend to have a bit of a low threshold to do a CT scan on them. So again, if we start kind of from basics, what kind of scan is this? This is not an aortic phase, not arterial phase, because that aorta sitting there is not as bright as the bone on the soft tissue window. And as we go to the portovenous system, sitting over here, the portovenous system actually looks slightly brighter than the aorta, so therefore there's going to be a portovenous system image. Gallbladder looks okay. That's a gallbladder there. No evidence of any gallstones. Pancreas looks okay. That's the pancreas, that fluffy looking thing sitting down the middle. And if we look at the kidneys, they all look okay as well. So when you're looking at abdominal pain, those are the kind of main things you want to be looking for. And then after that, you want to be looking at the bowel. And then you kind of got to do a little bit of legwork to look at the bowel. So if we look at, say, as soon as we start on this bowel, hopefully people can see this, yeah? As soon as you look at that bowel, you can see that the bowel wall looks a little bit hyperenhancing, looks a bit strandy along the outside. And as you kind of scroll through, that's a sigmoid colon, and you go to my constants, which is going to be the ascending and the descending colon. In this particular situation, we're looking at the descending colon. You can see it doesn't quite look the same as the bowel on the other side. And if you look at the other side, if you compare the two, look, bowel compared to bowel, yeah? Bowel compared to bowel on either side, this looks very much more collapsed, slightly thickened bowel walls, and this one kind of has a cloudy appearance, like the cumulonimbus clouds. I can't remember what they are, sorry, but you can see this doesn't have that appearance, and especially when you come up to the transverse colon, it just looks like a cylindrical pipe, right? And you can see that going along like so. It doesn't have very many features. It looks quite inflamed, and you're going along. It looks more and more kind of inflamed as you go along to this way, all the way along here, and then it starts to have more of a normal appearance within this region. So if someone's written edema in a sigmoid pattern, I don't usually use that phrase, because I guess if you're saying that it's only the sigmoid colon that's inflamed, then you may be saying something like colitis focused to the sigmoid colon, or what people may interpret as, is there diverticulitis? Is there diverticular disease? Is that what's going on? This is more kind of uniform inflammation. Now, if you say something like a segmental pattern, then you're going to start thinking about, is this conforming to vascular territories, right? So we've got a few vessels that supply the bowel. So you've got your left colic, you've got your middle colic arteries that supply the transverse colon essentially, and you've got your right colic arteries as well that supply some of the terminalium and the ascending colon. So if your inflammation only affects certain segments of bowel, then you've got to start worrying about whether there's ischemia, because what you're saying is that the blood flow to those segments of bowel is being affected. But when you've got what looks like quite uniform inflammation, the sigmoid colon going up the sort of down or down the descending colon and upon the transverse colon, you're looking at multiple vascular territories here. And so when you've got multiple vascular territories, you're less likely to be looking at ischemia. And so I wouldn't go with segmental inflammation. I'd just be going for sort of a uniform inflammation involving, and just describe it, sigmoid colon, descending colon, transverse colon, some loss of the normal features on CT as well. But the key things you want to take away from this is that there's no evidence of any perforation, collection, or fistula based on the CT images. And so this would more likely be in keeping with underlying inflammatory bowel disease, such as Crohn's disease. And remember, Crohn's disease can have skip lesions, so it doesn't just be inflamed on the large bowel, it could be inflammation of the small bowel as well. So you do have to have a look at the small bowel and just make sure there's no evidence of any focal inflammatory regions within the small bowel as well. Obviously, ulcerative colitis is going to be inflammation of the colon, the large bowel, and won't be affecting the small bowel per se. Right, so hopefully that was an interesting one. So hopefully, I mean, for those of you that are sort of kind of coming to these talks regularly, you can see that I'm starting to introduce a bit of cross-sectional imaging as we go through them, because the previous ones we were just kind of hammering a few x-rays, and to make things easier or more interesting, I'm going to start putting a few small CTs and working through it with everyone here.